No. All right. We'll see if we can change that. Is there still the myth that it's like really difficult and impossible to get into? There's still out there. Okay. Well, I got in, so obviously it's not impossible. Okay. So diabetic eye disease is really important. It's the leading cause of vision loss among working age adults in Australia and the world. If you saw the Australian of the Year announcement on the weekend, you'll see that it was an ophthalmologist from South Australia, James Mukey, and his whole messaging is around diabetic eye disease because unfortunately the incidence and prevalence is only going to increase with the demographics of our, of Western society. So for that reason, we're going to focus a bit on diabetic eye disease today. Start off with an overview. What is diabetic eye disease? So diabetic eye disease is really a microvascular disease or a microangiopathy. It affects the retina, but it affects other parts of the eye as well. Predominantly for our purposes, we'll be talking about diabetic retinopathy, but an example is people with diabetes are more likely to develop cataract at an earlier stage, and they have a slightly higher risk of glaucoma as well. So the retina is not the be-all and end-all, although it is the main site of the disease in diabetic eye disease. So as I mentioned, leading cause of avoidable blindness in people of working age, my age basically, 40 to 60. And it's a silent disease in the early stages, so you can have reasonably advanced diabetic eye disease and not even know it as a patient. So for this reason, as a non-eye specialist, a GP or any other type of doctor, eyes need to be on your radar anytime you see a person with diabetic eye disease because people need to be screened so we detect it early enough. And finally, in a nutshell, the management is systemic and ocular. So systemic, the best possible metabolic control, and I'll talk about the ocular management towards the end of the talk. So there's a normal retina on one side and a retina showing signs of diabetic retinopathy on the other. All the signs, and we'll go through them in a moment, but all the signs of diabetic retinopathy are consequences of blood vessels becoming incompetent, by which I mean blood vessels should be watertight and it should have gap junctions which prevent the contents of the blood vessel leaking into the retina. That's lost in diabetic eye disease. So you get leaky retinal vasculature, just like you get it in the rest of the body, in the kidneys and elsewhere. So as a result, you get leakage of blood, you get leakage of fluid, and you get leakage of lipid. And these are the signs that you see when you see an eye with diabetic retinopathy. So that's one endpoint, is leakage. The other endpoint is ischemia. So again, because of damage to the capillaries and because of damage to red blood cells and platelets themselves, you don't get adequate oxygenation of the retina. So you get areas of the retina that become ischemic, and that develops problems, which I'll talk about in a moment. But if you just remember that the two endpoints of diabetic retinopathy are vascular leakage and ischemia or insufficiency. And that explains every sign that you see almost at the back of the eye. So what are the risk factors? Look, they're similar to other end organ diabetic risk factors. So the most important one is how long has the person had diabetes, and this is type 1 or type 2, this whole talk. Poor glycemic control. So the magic number for us as ophthalmologists, based on our landmark clinical trials, is an HbA1c of 7, okay? So if it's HbA1c can be 7 or approach 7, that's been shown to reduce the progression of diabetic retinopathy significantly. The worse your HbA1c is, the worse the progression and worsening of vision in general. Other risk factors, hypertension, lipids, pregnancy and renal disease. You can develop diabetes during pregnancy, obviously, and if someone's already diabetic, their eye disease can advance quite quickly. So if you have a known diabetic who becomes pregnant, they need to have their eyes checked through their pregnancy. The pathophys, as I mentioned, it's basically microvascular changes leading to ischemia and leaky vessels. Let's get into that a little bit more now. So hyperglycemia via multiple pathways ends up resulting in microvascular change or microvascular damage, both to capillaries themselves, so you get loss of pericytes, you get a thickened basement membrane, you get weakened capillary walls, and you also get deformed red blood cells as well as aggregation of platelets, all of which lead to ischemia and leakage. And it's the ischemia and leakage and damaged capillary walls which explain your microaneurysms and retinal edema and hard exudates and some of the signs that I'll talk a bit more about in a moment. And finally, as the ischemia particularly continues, you get upregulation of a cytokine called vascular endothelial growth factor, okay? And as VEGF or VEGF is upregulated, you end up getting neovascularization. So the growth of abnormal blood vessels at the back of the eye, which are vision threatening. They can cause blindness in various ways. So our treatments, our ocular treatments, are targeted here and they're targeted here. So anti-VEGF drugs, which we inject into the eye, down-regulate the amount of VEGF for a limited period of time. So they do need to be repeated, initially monthly, every month. So there's people coming to our clinics every month to have injections in the eye for diabetic eye disease. And then if you have frank neovascularization in the eye, you need laser treatment. The back of the eye needs to be lasered to reduce the VEGF production and hopefully get rid of the new abnormal blood vessels. More about that towards the end as well. Any questions so far? Everyone happy? Okay, so let's talk about the classification of diabetic retinopathy now and why it matters. Why do we even need to classify it? So here's your approach to assessing diabetic. The basic approach is, what is the severity of diabetic retinopathy in this person? That's the first thing. And the second one is, do they or don't they have diabetic macular edema? And you can think about these two things really separately. What I mean by that is, you can have a very mild degree of diabetic retinopathy, so we'd call that mild non-proliferative diabetic retinopathy, with diabetic macular edema. So they don't necessarily go hand in hand. You don't have to have severe eye disease in order to have macular edema. Why does macular edema matter? Because it's the commonest cause of visual loss in people with diabetic eye disease. So when people lose vision from diabetes, it tends to be, in most cases, from macular edema. Not everyone, there are other causes, and I'll talk about those. But you need to be thinking, how severe is the diabetic retinopathy, and do they have macular edema or not? And don't forget about some of the other things that I mentioned at the start of the talk. Diabetes predisposes to other problems as well. So what is mild non-proliferative diabetic retinopathy? You start off, well, actually you start off with no diabetic retinopathy. So you look at the fundus with your ophthalmoscope and it looks completely normal. So you can be a diabetic and not have any visible diabetic retinopathy. The next mildest phase is mild non-proliferative diabetic retinopathy, which means you just have microaneurysms. Microaneurysms are tiny little pinpoint red dots at the back of the eye, which I'll show you in a moment, and that's all you have. So that's mild. I'm going to jump to severe, and then we'll come back to moderate. In severe non-proliferative diabetic retinopathy, if you think of the back of the eyes being 4 quadrants, top, bottom, left, and right, if you like, then all 4 quadrants, if they have hemorrhages in them, and I'll show you a hemorrhage shortly, then that's automatically severe non-proliferative. If you have 2 quadrants of venous beading, and I'll show you what that looks like. Venous beading looks like a normal retinal vein has sort of been, you know, like a string of sausages. It has that sort of appearance. And, you know, the amazing thing about the eye is you're seeing these microvascular changes where in the kidney or brain or peripheral tissue, you're not able to see it. IRMA, I-R-M-A, that's intraretinal microvascular abnormalities. I wouldn't worry about that at your stage. If you focus on the quadrants of bleeding and the presence or absence of beading, so bleeding and beading, that will tell you if someone's got severe non-proliferative. Anything in between severe and mild is moderate, okay? So if you've got 2 quadrants of hemorrhage, then that's moderate. If you've got 1 quadrant of venous beading, not 2, then that's moderate. If you've got hard exudates, which I haven't written up there, they're not really involved in grading, but if you've got microaneurysms plus hard exudates, that's moderate. Or if you've got microaneurysms plus cotton wool spots, anything but microaneurysms, and you're automatically moderate. And then if you satisfy the 4-2-1 rule up there, 4 quadrants of bleeding, 2 quadrants of venous beading, or 1 quadrant of edema, then you have severe non-proliferative. Okay? Just a bit more detail down the bottom. Of those severe signs that I've listed, if you have 1, there's a 15% chance of progressing to proliferative diabetic retinopathy. Proliferative diabetic retinopathy means there's neovascularization. So proliferation of abnormal new blood vessels. That's the most advanced stage of as far as severity goes, that's the most advanced stage. If you have 2 severe signs, you've got an almost 50% chance of advancing to proliferative disease in the next year. So that's non-proliferative diabetic retinopathy. Mild, moderate, severe. Then there's proliferative diabetic retinopathy, which means neovascularization. Neovascularization is often at the optic disc. So if you're shown a photo of a fundus, or you're examining someone who's got diabetes, and you're wondering how severe it is, the first thing you can do is look at the disc and inspect for the presence or absence of abnormal blood vessels. To be able to do that, you need to have seen lots of normal funduses, fundi. So make sure you do that as you go along. Abnormal blood vessels look different to normal retinal vasculature. They're more fine and they're more frilly. They look like a little collection of lace. Hopefully I've got some photos to show you. Once you've got neovascularization, those new vessels tend to bleed. This is the problem with neovascularization. The vessels tend to be incompetent. Sooner or later, they cause what's called a vitreous hemorrhage. So that's a bleed into the vitreous jelly, you know, the jelly at the back of the eye. So a person rapidly loses vision in one eye because they've had a bleed into the vitreous. Neovascularization can also exert traction on the retina. So it grows up out of the retina. And as it grows, it can tug on the retina essentially and cause a retinal detachment. So you can get a diabetic tractional retinal detachment. That's another possible complication and cause of blindness. And finally, less common, but if you have neovascularization of the iris, okay, the front of the eye, those blood vessels can also bleed and cause a hyphema. So who knows what a hyphema is? Yeah, definitely redness. And the redness tends to be in the anterior chamber. So in front of the pupil, but not necessarily extending out into the conjunctiva. So you'll see like a blood level in the front part of the eye. Again, hopefully I've got a photo to show you. So if a diabetic turns up without trauma, I mean, if you punch someone in the eye, they may get a hyphema. But if a diabetic turns up with a spontaneous hyphema, then that's neovascularization of the iris, really until proven otherwise. And as I mentioned earlier, so in addition to all of this, so we've now graded the severity. You then want to assess for the presence or absence of diabetic macular edema. Your best clue when the person walks in the door as to whether they've got diabetic macular edema or not, well, A, they need to be diabetic, and B, vision's down. And it's not a rapid or instantaneous loss of vision. A retinal detachment or vitreous hemorrhage is rapid or instantaneous. But diabetic macular edema tends to be gradual, chronic, or at most subacute, so weeks. It's not normally days, hours, or minutes, okay? So that's one way. That's the minute they walk in the door, that's your first sign. Sometimes people don't even notice it. So you've got to check the visual acuity. So if they're 6/6 in one eye, you might know 6/6 is normal vision, okay? Someone 6/6 in one eye and 6/9 in the other eye, they might not actually notice that the 6/9 eye because both eyes are open and they're seeing well enough. So unless you check the vision one eye at a time, you won't know. That's quite a sensitive way of checking. So here's just a bit more detail on the stages that I talked about. So the normal fundus is there. Don't worry about the letters at the bottom, the R0, R1, that's a classification system. There's no picture of mild non-proliferative in this series. It starts off with a picture of moderate. And if all you can identify, if you look at the first image, the normal fundus, and then the second one, if all you can say is there is red stuff within the orange tissue which isn't present in the first picture. Do you agree with me? Just looking for a laser pointer, but I can't see one. So if you look at the first picture, you've got a bright yellow disc, that's the optic disc. Then you've got retinal blood vessels emanating from the optic disc. You've got a darkish red sort of central circle, which is the macula. The macula is the part of the retina that is responsible for sort of high definition color vision. You know, you looking at me right now, you're using your maculars. The rest of it is plain orange tissue, more or less. If you look at the second image, within that orange tissue, you've got scattering yellow and red lesions. The red are hemorrhages, the yellow is hard exudate. That stuff doesn't belong there in a normal eye. So straight away you can say there's retinal hemorrhages, they appear to be hard exudates, and this is suspicious for diabetic retinopathy, let's say, if the person has diabetes. If you look at the next one, you could just see that there are more hemorrhages. Yes? Yep. So the question is, are the hard exudates lipids? Yeah, the answer is yes. So if the blood vessels lose their competence, then you get exudation of lipid, red blood cells, transudate, cytokines, all kinds of stuff into the retina. And they're literally cholesterol, lipoprotein deposits within the retina. You probably can't make it out on this image, but there is venous beading on the severe non-proliferative picture. And more than that, you can just see there's lots of blood. And then finally on the last one, just superior to the optic disc, there's a little neovascular frond. So these are small pictures, but if there was a magnified version of that image, if you look above the optic disc in the other images, you don't see that little fluffy collection of blood vessels, whereas you do see it in the last image. So that's a neovascularization at the disc, which means this is proliferative diabetic retinopathy. So a little bit more about PDR. There's a better image there of a massive neovascular frond. Can everybody appreciate that? You've got this squiggly, very lacy looking collection of blood vessels that shouldn't be there. So it's caused by the ischemic retina, as I mentioned. 50%, if you don't treat these guys, half of them go blind in 5 years. So it's ideally they're detected before they become proliferative. But if they do become proliferative, they need immediate referral to ophthalmology, and there's various things that we can do for them. I'll talk about those more in detail at the end. What about diabetic macular edema? So if you look at the image there, in the central macula, so within the center, you'll see there's blood and there's hard exudate, which means leakage is happening in that area. If you've got leakage happening in the central macula, it's very likely that there's also edema in the central macula. So if the case here, for example, is this person comes in with 6/12 vision in the right eye, and here's their fundus and they're diabetic, if you put those things together, you should be able to deduce basically that this is a case of diabetic macular edema. What's the severity of, so we're happy that there's diabetic macular edema here. Who wants to have a go at, yeah. Yeah. Yep. It doesn't matter. You can take the macula as the center or you can take the optic disc as the center. the images that you guys get usually will be centered over the macula. So if it's centered over the macula, use that as your reference. Yep. So this is a moderate non-proliferative. There's little dot microaneurysms you can see around the place. Definitely there's some hard exudate, but there actually aren't many big hemorrhages. What you're seeing more there is microaneurysms. So this is moderate non-proliferative plus diabetic macular edema. So 10% of patients with diabetic retinopathy will get diabetic macular edema. And as I said, it's the most common cause of vision loss. What's the treatment? Always the treatment is good systemic metabolic control of diabetes. It always starts with that. So you need a good GP or endocrinologist to be involved. And then when you've got macular edema, which is affecting the vision or has damaged the vision, then often these are the patients that we do intravitreal injections of that anti-VEGF medication for that I mentioned earlier. We also inject steroids sometimes. There is a role for steroids. It just depends. And there can be a role occasionally for laser too. You guys don't need to know the details of a sort of treatment algorithm. More you need to know, this is diabetic macular edema. It's bad. It can cause vision loss, needs urgent referral. You may get an injection. You may get laser. That's the sort of gist of it. And you know, what's your HbA1c, blood pressure, lipids, all that stuff. Just briefly, we don't need to spend too much time on this, but briefly, you're at a higher risk of developing cataract if you have diabetic macular edema or diabetes, okay? PSCC means posterior subcapsular cataract. It's a type of cataract which often comes on more rapidly. So this is another cause of rapid vision loss in a person with diabetes. So you go to examine them and you can't even see the fundus because the cataract's in the way. Cataract is a cloudy lens, right? So you go to examine a diabetic, can't see the fundus. Cataract is one possibility. What's another possibility if you can't see the back of the eye? Detachment is a possibility, but if it's just a detachment, often you will see the back of the eye. It will just look weird because the retina is detached. But what else might obscure your view of the retina? Can't even see the retina. Mentioned it a couple of times. Yeah, I mean, infection can always obscure your view. But if you think of the eye as a transparent organ, okay, it should be transparent from front to back. Then if you can't see the back, then potentially it can be any structure in front of the retina, which is obscuring the view of the retina. So it could be a corneal problem, could be a lens problem, could be a hyphema in the anterior chamber, it could be a vitreous hemorrhage in the jelly of the eyeball. So most commonly in a diabetic, it's going to be a vitreous hemorrhage if you can't see the back, and it will kind of look reddish when you go to examine them. Okay, so here's some pictures. So do you guys, diabetic macular edema, yes or no? Yes, put up your hands. No, put up your hands. Too scared to put up your hand, put up your hand. This, I don't think there's, look, there might be, but it's not, there's not heaps of activity around the central macula here. There's a few microaneurysms above the macula, superior to the macula. There's some hard exudate temporally. By the way, how do you know if this is a right or left eye? Does anybody have a way of, who thinks it's a right eye? Yeah, why? So, do you have a way of, you just know? Sorry? Yeah, look, you might just intuitively have a way of knowing, but whenever you see a fundus picture, the patient's always looking at you. So imagine that it's the eye looking at you, okay? And the position of your landmark is the optic disc. So if you, or the optic nerve, we also call it the nerve. So if you remember the sort of a little acronym, the nerve is always nasal. The nerve is always nasal, okay? So if the nerve is nasal, that means the nose is over there. So this has to be a right eye, okay? The macula's more temporal than the disc or the nerve. So what do I mean by non-central changes? I mean they're not smack bang in the middle of the macula, making it less likely that there's diabetic macular edema. A lot more activity in this one. Okay, do you guys agree? There's hemorrhages all over the place. There's microaneurysms as well. So I've pinpointed what microaneurysms look like. Query diabetic macular edema. Definitely this person would be at risk. Possible Irma lesion. Again, don't worry too much about that. Cotton wool spots look like little fluffy balls of cotton wool. They look different to hard exudate. So hard exudate tends to be smaller and more brighter yellow. Cotton wool spots are more a marker of ischemia, whereas hard exudates are more a marker of leakage. Either way, it's at least moderate non-proliferative, if not severe, because there's more than just microaneurysms going on. It's just some more pictures of cotton wool spots, okay? So white fluffy things. They're in the superficial retina. Now this is a good picture of venous beading. So if you look at those two superior branching vessels, do you see that sort of sausage appearance where the veins look like they've been pinched in? So there's definitely two quadrants of venous beading there. Also, do you see the white dots in the superior part of the fundus, and some of them are pigmented, they've become black? So that's what laser scars look like. So this person has had laser, they've got venous beading. Generally, we only do laser if someone's got proliferative diabetic retinopathy. So you could look at this picture and say, this is at least severe because I can see venous beading. And I can see laser burns too, which then makes you go and look for neovascularization. So if you look at the optic disc, you'll actually see some squiggly blood vessels overlying the optic disc, which aren't normal, and that's neovascularization. So there's the venous beading. There's the neovascularization. The macula just doesn't look normal. Do you agree? It's pale and there's blood around it, and the vessels are telangiectatic. You know, they look more squiggly than they should. So there's a very high likelihood that there's macular edema here. And that's just pinpointing a retinal hemorrhage. And laser burns. So this is a good image of diabetic macular edema. So it's all in the middle. The changes are all in the central macula. Again, it's the right eye. There's hemorrhages there. These are not cotton wool spots. These are hard exudates, which tells you there's leakage there. So that this macula is going to be swollen and edematous, and the vision's going to be down. There's a picture of a hyphema. So if you look at the bottom of the anterior chamber, can everybody see that little red fluid level? So that's what a hyphema looks like. And if you up the magnification on the slit lamp, you'll actually see tiny little frilly blood vessels where they don't belong on the iris margin. Okay. So this is proliferative diabetic retinopathy. This is really just to say there are new imaging techniques now where we can see really far peripherally in the retina. So if you were just looking at the central macula in this person, you might not see a great deal. But with the imaging devices that we have now, and optometrists have too, we're able to detect other diabetic retinopathy changes, which, you know, a generation ago we wouldn't have been able to see. So we can catch people earlier and treat them earlier, which is good. What about Indigenous patients? I do a lot of outreach work to various communities. And like many diseases, unfortunately, there's more diabetic retinopathy at an earlier stage, more severe in Aboriginal compared to non-Aboriginal people. Various reasons for that. But just to briefly give you an idea, in general, the prevalence of blindness and vision impairment is higher in Aboriginal compared to non-Aboriginal Australians, 3 times higher. And there are various reasons for this. One of them is cataract. So this is us operating up north. If you look at the picture up the top, this is a typical sort of cataract that you might see in Perth, which is not that dense, really. But if you look at the one at the bottom, even if you've never seen pictures of cataract before, you can sort of appreciate there's something white there in the middle of the eye where it doesn't belong. That's a very, very dense cataract. And you don't tend to see as many of those. You know, you get more late presentations out in rural, remote communities than you do in Perth. So just be aware of that. I'll touch on the significance of that shortly. So what are the principles of management? Well, there's a few things, but screening, systemic management, and then ocular treatment, stuff that we do. As far as the screening, people ask how often should people be screened? It depends on a few things. So if you have no diabetic retinopathy, then you should have your eye screened at least once every 2 years. These are the Australian guidelines. More frequently, if there are any signs of diabetic retinopathy, then that person should be seen more frequently than every 2 years. If there's a suspicion of diabetic macular edema, or if there is diabetic macular edema, obviously they need to be seen more often. If their metabolic risk factors are worse, so they have worse glycemic control, or they've had diabetes for longer, hypertension, lipids, all that stuff. And finally, for Indigenous patients, because of what I just talked about, the guidelines for Aboriginal patients is for screening to happen every year. So if they've got no visible diabetic retinopathy, they should be screened every year for safety. This is interesting. For every 1% decrease in HbA1c, there's an approximate third reduction in the risk of microvascular complications. So I think that's a good way of encouraging people to try and optimize their HbA1c. You know, when you talk to patients about dietary changes for diabetes, it can be a bit depressing. They just think they have to have this miserable, boring diet. But you can emphasize all the stuff that they can eat, which are excellent nutritional sources and not high in sugar. And don't forget to talk about lipids and blood pressure as well. As far as ocular treatments go, we talked about laser. So this is what fresh laser looks like. By fresh, I mean it's just been done. Once those laser burns sit there for a few weeks, they'll become pigmented, so they'll actually look like black spots. But if you see that sort of white dot pattern at the back of the eye, the only thing that can do that is laser treatment. Nothing else really looks like that at the back of the eye. So this person's actually got a trace of vitreous hemorrhage. Do you see along the bottom of the image, there's sort of a horizontal sort of sliver of blood? So that's sitting inside the vitreous. That's not normal. And that's why they've been lasered. They've also got neovascularization at the disc. So again, if you look carefully, you can see this frilly sort of blood vessel appearance over the disc. If someone has a big vitreous hemorrhage, then they get what's called a vitrectomy. So this is where the vitreous jelly inside the back of the eye is actually removed with a vitrectomy operation and replaced with clear fluid. So that's a way of rapidly getting rid of blood. Those people can rebleed, obviously, so they need other treatments. But big vitreous hemorrhage, that person may need a vitrectomy, okay? And this looks horrible, but actually injecting the eye doesn't hurt at all. We do it all the time. Obviously, we give subconjunctival anesthetic, so people don't feel the needle. But as I mentioned earlier, the injections do need to be repeated fairly frequently. So the average in Australia is 8 injections in the first year, and then it tends to taper off after that. The injections tend to be for diabetic macular edema, but they do have a role in proliferative diabetic retinopathy as well. So just remember anti-VEGF and steroid injections for more advanced diabetic eye disease. These are some of the drugs that we inject. So these are all anti-VEGF preparations, different drugs. And this is one commercially available steroid injection that we do. You don't really need to know the names of these. But if you're seeing a lot of diabetics, you might see it in their documentation. So you just need to know these are intravitreal injections for diabetic eye disease. In the future, it's likely that emerging technology, I mean, they kind of already are starting to play a role. So retinal screening using an iPhone is done in some parts of the world. We don't really need that here in Australia because we've got devices in every country town, but it's got applications in other parts of the world that aren't as well resourced. Google and IBM and other groups all now have artificial intelligence technology that can grade a retinal photograph. So instead of us having to screen them, a computer can do it, and then in theory, we just see the ones that have more advanced disease. So within our lifetime, all this stuff's going to be playing a role. And then finally, there are semi-automated ways of doing laser. So the laser device, at the moment, it's me sitting in front of the patient and lasering the right parts of the retina. Obviously, if you laser the macula, you're going to blind the person. So it's really important that you don't laser the wrong areas. But there are devices now that do anatomical registration. So the machine registers all the different anatomy at the back of the eye and won't laser the wrong parts. I haven't used that myself, but it's commercially available. And finally, there's some research work being done at the moment into robotic intravitreal injections, where again, it's, you know, the machine does anatomical registering. So if the person moves their head or their eye, it can adjust where it's injecting. Why do we need this stuff? It's because the prevalence of diabetic retinopathy is going up. So the volume of people that need to be treated is going up, and we need better ways of coping with it. The best way of coping with it is to not get diabetes, obviously. And again, if you listen to James Mukey's comments, he was talking about a sugar tax. If any of you heard that, there's other places in the world that have implemented that as part of a multi-pronged approach to tackling diabetes. So that's the sort of conversation I think we need to be having in Australia. Okay, this is just a glossary. I use some abbreviations in this talk, and also in the other lectures that are online, there's a few abbreviations, so these will help with that. And that's about it for today. Take-home messages, I guess. Diabetic retinopathy is common. Think about it with every diabetic patient. Make sure someone's checking their eyes, because often they won't have had their eyes checked in 5 years or ever. And that's the person who turns up with a vitreous hemorrhage or blind. So everything we're trying to do is get people into screening earlier. So if you see the word diabetes, include eyes in your sort of overall systemic assessment. Okay, thanks everyone.